Okay, Assalamu alaikum ji. Thank you very much, everyone, for coming to this important session. So we will start this session. This session is about infectious diseases in cancer patients, and as you all know that this is one of the leading cause of deaths in immunocompromised patients. So we will start our session, and I would like to request Dr. Zartash to chair this session because originally Dr. Altaf was supposed to chair this session, but he had some emergency. So Dr. Zartash is an infectious disease consultant, and she is chair antimicrobial stewardship committee as well in Dubai Health. And she's an American-trained infectious disease and internal medicine physician. So I would request Dr. Zartash, please come on as to share the session. And I will be the co-chair of this session. I'm Dr. Anraza, and I'm a consultant in infectious disease and general medicine at Shaukat Khanum Hospital. So we'll start the session, please.
Hello, everyone. Assalamu alaikum. Dr. Zitash, welcome over here to the ID session. So our first speaker for the session is Dr. Sumaya Nizamuddin. She is a consultant microbiologist, section head of microbiology at Shaukat Khanum Medical Center and Research Center. And she's the president of Medical and Microbiology and Infectious Disease Society of Pakistan. So welcome, Dr. Sumaya. She'll be talking about changing epidemiology of gram-negative bacteria in cancer patients.
Okay. Thank you, Dr. Zatash. So, Assalamu alaikum. So I'm Dr. Sumaya. I'm the consultant microbiologist at Shaukat Khanum, and we'll be talking about the changing epidemiology of gram-negative bacteremias in cancer patients. So this would be an overview of the data that we went through over the last couple of years, and then we'll be looking at how pre-COVID and post-COVID the epidemiology of gram-negative infections actually changed in the cohort of patients that we actually come across. So why gram-negative bacteremia matters in cancer care? So we all know that, of course, we look at a group of patients who are already high risk because of chemotherapy, neutropenia, because of multiple lines that are inserted into them, and of course there's the gut translocation of the gram-negative bacteria, and it just makes invasion of the bloodstream fairly easy. Pointer hai kya? I'm sorry. And of course, ये तो हम सबको ही पता है कि once our patients get infected with gram-negative bacteria, sepsis can set in fairly quickly. And of course, so we need to start appropriate antimicrobial therapy. It needs to be started early. It needs to be started fast in the right dose. And of course, it has to cover the bacteria that we are actually suspecting. There has been a shift in the groups of bacteria that actually cause the most predominant infections in our subsets of patients. And we feel that there has been a certain shift in the species over time, especially in and around COVID. So what we need to find out is, do the empiric choices that we used to use before COVID, are they still effective today? And of course, rising resistance, everybody knows this, especially in our part of the world. CREs, carbapenem-resistant Enterobacteriaceae, are no surprise. There's an increasing infection, increase in infections caused by non-fermenters, such as Pseudomonas, Burkholdeриas, Stenotrophomonas. We've seen an increased rise of infections with these organisms as well. And of course, infections, sepsis ultimately come down, also have a financial impact because of longer stays, ICU stays, and at the end, they lead to higher mortality and morbidity. So what do we need? We need risk stratification, we need timely cultures to be taken, and of course, evidence-based medicine needs to take place over here by using data to make the right empiric choices for your patients. So this is why tracking the changing spectrum of susceptibility in our own center is very critical, and this will allow us to make empiric choices, shorten time to effective therapy, and promote antibiotic stewardship. So this is our motto for today: local epidemiology will drive your empiric choices and your stewardship. So why study epidemiologic change? Like I said, species will mix, resistance shifts will take place, care pathways change during COVID-19, admission thresholds, cohorting, device dwelling time, all of these were affected. There was a lot of antibiotic misuse, there was ICU overload, and of course, this also affected our staffing patterns. And these dynamics can alter the incidence spectrum and susceptibility of the prevailing pathogens. So before COVID, Enterobacteriaceae were the predominant bug that was seen, and this dominated the bloodstream infections in cancer patient. Non-fermenters were more commonly seen where lines were involved or where ventilatory support was provided to the patient. Overall, resistance rate was on the high. We've all seen resistant rates go up with Enterobacteriaceae in ESBLs as well as in carbapenem resistance. And of course, difficult to treat pseudomonas were also seen. And we were not the only ones who were, actually encountering this. There were numerous publications. I've just added an example of one where the same sort of picture was seen in other cancer care centers. And resistance, and of course, because increasing resistance limits our treatment options, and of course, that ultimately leads to high morbidity and mortality. No surprise about that. And again, in COVID, what happened, like I just previously mentioned, pandemic actually affected everybody. Resources were impacted, treatment strategies and pathways were affected, led to higher hospital-acquired infections, higher AMRs in many settings, and other centers also saw an increase in Acinetobacter infection rates and Acinetobacter antimicrobial resistance. And lower susceptibility were also seen in many centers around the world, especially in Southeast Asia, with high increase in resistant rates in Enterobacteriaceae that's especially causing your bloodstream infections. So yes, again, another example of your rising AMR issues. So what did COVID do? So it reshaped hospital epidemiology, and it saw the increase in AMR in various bugs. Data sets were affected. And of course, the whole idea of bringing this talk together was to actually look at the size of the data that we produced during this time, and where exactly is the trajectory of AMR in our own bugs. And this is why we opted to look at the last 10-year data of our own center. So the objective of basically my talk for today is that we'll be presenting our hospital's epidemiology of gram-negative bacteremia that was seen in our cancer patients, and we'll be comparing the pre-COVID and post-COVID data, so that we have one subset of 2015 to 2019, and another subset would be from 2020 to 2024. And our we'll be focusing more on our Enterobacteriaceae and our Pseudomonas, and how the data will actually help us in guiding our empiric therapy and our stewardship. So this was a retrospective observational study. Obviously, the data was our own. This was a single center oncology hospital, obviously. These were our data sets, and we went through all our online medical records to get the data. Obviously, all of you know that multiple blood cultures are drawn when our patients suffer from bloodstream infections. So we opted to count in only the first positive culture that was picked up from these patients. So duplicates were actually removed. And we were only focusing on bloodstream infections, so other specimens were actually ignored. So this is to give you an idea how many blood cultures were actually sent before COVID and how many blood cultures were sent after COVID. So this divides our cohort. So you can actually see that the marked increase in the blood cultures that were actually received by our own lab. So this is just our lab. These are just our own cancer patients. Another reason why the blood cultures went up, one, obviously, people learned more about sending blood cultures at the start of infection. We introduced our neutropenia pathway. I'm sure most of you are already aware that when a patient actually arrives to our emergency, we will ensure that 2 blood cultures are actually taken from such patients before the start of antibiotics and sent immediately to the lab. So this actually helped us. And you can see that the blood cultures received by the lab post-COVID went up and are still on the high. But positivity rate has decreased, and I can actually explain why this is happening. So pre-COVID, our positivity rates were in our 20s, and post-COVID, the rates actually went down. So when we analyzed our data, we actually saw that pre-COVID, there was a lot of issue with our blood culture contamination rates. People, our staff members and our phlebotomy teams were actually facing the issue of blood culture contamination, which obviously, as you know, will not help us find out what the actual bug is. So we actually introduced various methods to bring the blood culture contamination levels down. We introduced videos and checklists. We trained teams, targeted teaching, sessions for repeat offenders. So that actually helped us bring our blood culture contamination rate down. And so what we're looking at over here is actually the true representation of what the actual pathogens that are causing infection over here. And what is this? So once again, when we pulled the numbers out, we saw that the number of organisms that were identified in these, though in these blood cultures, were also on the high. So you saw that even though the blood cultures, the positivity rate was going down, the numbers of bacteria that were actually being identified in the in these blood cultures are actually going up. So we're actually identifying more bugs that are actually causing the infection. So if I had to break this number down, if I had to break these number down, this is what we actually came up with. So up till now, in these last 10 years, almost 6,000 bacteria were identified, and this is an entire list of them. So obviously, you don't have to go through the whole thing. I've just made it a little easier by breaking this down into a pie chart. So what we saw was that at least 44% of our infections are being caused by E. coli, and something that is different from other cancer centers that we see around the world is that we also have a big chunk of salmonella infections in our patients, followed by Klebsiella, Pseudomonas aeruginosa, and the smaller subsets include our other non-Enterobacteriaceae. So, but we can still see that Enterobacteriaceae is still causing most of our infections in our cancer patients. E. coli, so pre-COVID E. coli, this is the trend. So these are number of blood cultures versus years. So this is our E. coli trend before COVID, and we can see that post-COVID, again, it's on the high. Once again, increasing blood cultures, increased identification, and of course, because we see patients who are actively being in, like I said initially, gut translocation, lines, mucositis, all the more reason why E. coli tops the list as the top cause of infection. Salmonella, what did we see in Salmonella? We actually saw a high in 2019, and the numbers went down post-COVID, and then again, once again, the numbers went up. So why was this happening? As many of you might know, there was an outbreak of the XDR Salmonella typhi. It actually reached Punjab somewhere around end of 2018. And in 2019, we saw an outbreak of XDR typhi across the province and across the country as well. So this was just a reflection of that in our own patients. Post-COVID क्या हुआ? Post-COVID lockdown लग गया. Post-COVID, people were not eating outside. Post-COVID, people were actually behaving themselves, and they were, non-pharmaceutical interventions actually came into place. So this is a reflection of that. So, and we actually wrote up about this. So the 2019 outbreak, this paper was published from our center. So we actually saw the increase in Salmonella typhi and paratyphi was not just seen in our own cancer patients. This was also seen in the samples that we get through our collection centers. So the outbreak was actually taking place. And we wrote up another paper about looking at the trends of typhoid in COVID. And this is also what we saw, that the numbers of typhoid actually went down around the time where the lockdowns were taking place. But even though the numbers of positive typhi cultures went down, XDR typhi still was on the rise. So this is what this graph represents. The XDR numbers were still going up. Klebsiella pneumoniae. So the numbers compared to E. coli or Salmonella are comparatively lower, but we did see a spike in around 2021-22, and numbers are still under fairly controlled. And this is our non-fermenter. So the top non-fermenter, Pseudomonas aeruginosa, we're just seeing an up and down in the numbers of Pseudomonas aeruginosa that are identified mostly, and these are mostly in patients who have lines, more patients who are mostly on ventilatory support. So any exogenous factor that might lead to the introduction of Pseudomonas, these cases are mostly seen in those scenarios. So if I had to overlap all of this, you can just see के E. coli का impact. This is our E. coli, and this bump over here is our Salmonella. And you can see the remaining of the non-fermenters are fairly at the bottom. So our prime masla is E. coli, right? So here we're looking at the susceptibility trend for E. coli. I just picked up piperacillin tazobactam and meropenem. So this is how our piperacillin tazobactam has actually behaved over the years. We're seeing a general decline in the susceptibility rate of piperacillin, and we are also seeing a decrease in susceptibility rate of E. coli. And this is not just our center. This is reflective of almost all the centers in Pakistan. So if anybody's interested, there's a website called PAN, Pakistan Antimicrobial Resistance Network. So most of the bigger centers in Pakistan, they actually upload their antibiograms on these websites. So just go over there and you can actually see that this is what the resistant trend for these major antibiotics is is at other hospitals. Salmonella, what do we see in Salmonella? So before our XDR outbreak, we were seeing 100% susceptibility in our cephalosporins, where ek dafa wo XDR typhoid aaya, this is what actually has happened. We've seen the ceftriaxone and cefixime susceptibility rate go down to 65 and 66%. ये जो आप यहाँ पे देख रहे हैं, ये नहीं हुआ है कि ceftriaxone अब sensitive होना शुरू हो गई है. What is actually happening now is we're seeing an uprise in the numbers of Salmonella paratyphi A. So Salmonella paratyphi A is still universally susceptible to cephalosporin. So we are seeing कि XDR के numbers कम होते जा रहे हैं, but we are also seeing कि अब जो है Salmonella paratyphi A के numbers बढ़ते जा रहे हैं. So still अगर आपके पास अब patient आता है and you're still suspecting typhoid, अगर आप cancer patient में typhoid suspect कर रहे हैं, तो your cephalosporin might still be effective in this scenario. Then Klebsiella, again, same issue that we are seeing in our E. coli. So again, susceptibility rate of piperacillin tazobactam, piperacillin tazobactam and meropenem, carbapenems are still on the downtrend. We're still seeing a sort of variability, but then it all depends on what the individual bug is. Pseudomonas aeruginosa, the good part is कि जो हमारे अस्पताल का Pseudomonas aeruginosa, it's still behaving fairly well. So even though I'm just showing the data here for piperacillin, tazobactam and meropenem, ceftazidime, cefepime, ciprofloxacin, our Pseudomonas aeruginosa is still fairly susceptible to our major classes of antibiotics. So what are we seeing? So pandemic increased device days, ICU loads, trained IPC, broad spectrum antibiotic use was seen, and there was obviously misuse of our antibiotics. And everybody else saw that the carbapenem resistant rates were on the high, and high antibiotic prescribing was also seen despite low evidence of actual infection. But we saw that the antibiotic misuse was on the high, and it is actually reflecting on our own data over here from Pakistan. So our findings, what were our findings? We saw that E. coli still is the leading pathogen in our scenario. Enterobacteriaceae infections are more commonly seen than your non-enterobacteriaceae. Carbapenem resistance is still on the rise. Overall, AMR is on the rise. But unfortunately, we don't have many new antibiotic options that are coming into the country that we could actually use to replace our empiric choices. But this is what we have. So what can we actually do at the moment? We'll have to keep an eye on our local data. We'll have to ensure that at least antibiotic options such as ciprofloxacin or gentamicin are not used as monotherapy in high risk patients. And still, we would actually come down to consider meropenem as an alternative option instead of your piperacillin tazobactam as your empirical choice if your antibiotic resistance for tazobactam continues to increase. We'll have to enforce better IPC practices. Stewardship and prevention would need to be reinforced, and infection control will continue to play a very important role if these infections need to be controlled. We know that these infections come with high mortality, and of course, so rapid initiation of appropriate antibiotic will need to be initiated before the onset of sepsis. This study did have its limitations. It is single center. It is retrospective. We haven't segregated the data into adults and pediatrics, but still, we are seeing that pediatric patients will also are seen with the same spectrum of organisms. And of course, we did not look at the admission volume either. I'm sure everybody faced this, that admission numbers went down during COVID. There was a denominator issue. We'll have to segregate that data and look at it more closely. Culture and testing practices, yes, definitely. I think post-COVID, our neutropenic pathway was implemented rather strongly, and we saw that more samples were coming in. So obviously, blood cultures that were actually taken went up, practices improved. And as I said, though our findings also reflect what the antibiograms across the country are showing, but generalizing our data would need caution. So next step would be to continue to perform surveillance. We'll have to come up with the denominators. We'll have to look at the device days tracking and actually conduct pre and post protocol audits. And of course, treatment time series will have to be conducted as well. So yeah, that brings me to the end of my presentation. This was just a snapshot of the antibiogram of Khan that I actually took. So these are their adult patients. So you can actually see कि इनके भी हालात तकरीबन हमारे ही जैसे हैं. Right? All right. I think that's the end of my talk. Right. I can take any questions.
I think we'll take questions at the end of
Okay.
the session. Yeah. Thank you.
Thank you.
Okay, thank you, Dr. Sumaya, for a very informative talk. So our next speaker is Dr. Zartash Zafar Khan. She's a consultant infectious disease at Dubai Health in Dubai, and she will give us an overview of neutropenic syndromes in cancer patients. Dr. Zartash.
Hello, assalamu alaikum, everyone. First of all, thank you to the organizers for inviting me to speak today. It's a real pleasure being here. I don't want to echo in your heads over there. Can you hear me okay? Right. So my talk is about neutropenic syndromes in cancer patients. So a brief overview, we will first settle on the definition of the neutropenic fever. Then we will talk about risk stratification. Then we will talk about some lessons learned from some cases. I picked out, I think, 4 cases. And then we'll just talk about a little bit of pathogens, common, uncommon, diagnostics and management principles, and so forth. So first of all, the definition is sort of unanimous. So febrile neutropenia is a temperature of 38.3 degrees Celsius or a temperature of 38 degrees that lasts for a period of an hour to 2, along with the neutrophil count of less than 500 or a predicted decline of the ANC to less than 500 over the next 48 hours. What causes neutropenia? Obviously, in the setting of cancer patients, chemotherapy, radiation, and post-transplant myelosuppressive agents. And in addition to the immune modulators that we use post-transplant, certain antibiotics, including trimethoprim, sulfamethoxazole, ganciclovir, which we use post-transplant, also cause the neutropenia, myelosuppression. When we talk about myelosuppression, we also have to bear in mind that we're not only suppressing the myeloid precursors, we are also suppressing the lymphoid precursors, and thus we are compromising the humoral and cell-mediated immune system as well. So the risk of infections in the setting of neutropenia depends upon the extent and duration of neutropenia, patient's cellular and humoral immune suppression, clinical risk factors such as age, advanced age are at the highest risk, type of cancer, type of treatment, and type of and comorbidities, disruption in skin and mucosal barriers, like if the patient has a central line or an ulcers, or if they have mucositis, and alteration in microbiome composition with prior antibiotic use. Risk stratification, the patients with acute leukemia are at the highest risk, followed by other hematological malignancies, followed by solid organ tumors, about 5 to 10%. There are certain scoring systems that are used to risk stratify these patients that help us in setting up a management strategy. The shorter the duration of neutropenia, the stable the patient is at clinically, they're considered low risk and can be treated as an outpatient. Or if there's a prolonged neutropenia or profound neutropenia of less than 100 ANC and patient looks unstable, they are considered high risk and they should be admitted and closely watched. These are some of the scoring systems. MASC-C score is the one that is most followed. It's a multinational association of supportive care in cancer score system. This entails these following criterias, and each criteria has a weight. So these, if the patient has febrile neutropenia along with symptoms mild to severe, no hypotension, chronic obstructive pulmonary disease, type of cancer, presence of dehydration, outpatient status, age less than 60. So the higher the score, the better it is. Most organizations use a cutoff of 21. If the score is less than 21, they're considered high risk and need to be closely watched. The second scoring system that is commonly used is a clinical index of stable febrile neutropenia score. And again, these are the criteria that are utilized in this score system. And in this setting, the higher the score, the worse it is, actually. So again, as you can see, these are including hypoglycemia, monocyte count, mucositis, prior infections, and so on. So the lesson from this is basically these risk scoring systems we can apply, but they are more applicable to outpatient settings or an ER setting when we have to decide when we have to make a judgment whether if the patient needs more advanced care or can be treated as an outpatient. So moving on to my cases, these are all inpatient cases, more sick cases, so these risk stratification systems do not apply to them. This is a 57-year-old lady with acute myelogenous myeloblastic leukemia. She was started on chemotherapy and she was referred to ID 1 month later with severe myelosuppression, and she had this lesion on her CT scan. Any takes on that? ID? Yeah, so you can see the crescent sign on the top left. Pointer works right there, and other infiltrates also. So her aspergillus galactomannan antigen was positive, the antibody was positive, beta-D-glucan was negative, histo was negative, her IGRA were positive with high mitogen value, sputum and BL fluid were negative for AFB and MTB-PCR, and the culture grew aspergillus fumigatus. She was treated with voriconazole. 12 weeks later, her CT scan was much improved. She was clinically improved. She was continued thereafter on voriconazole prophylaxis. And also she was treated empirically for TB. She was started, as you know, the AFB cultures take 6 to 8 weeks. So she was started on TB treatment, which actually was continued as a therapeutic regimen later on. So unfortunately, her AML relapsed. She was restarted on chemo, including intrathecal chemo. She was planned to for a bone marrow transplant, but unfortunately had multiple comorbidities, infections. She had central line-associated bacteremia with Corynebacterium, which is actually a skin commensal, but in setting of neutropenia, it can be severe. She also had vancomycin-resistant Ephysium bacteremia. And while she was on daptomycin, meropenem, and prophylaxis with trimsulfa, valacyclovir, voriconazole, she developed high fevers, acute onset hematemesis, hemoptysis, hypotension. And as you can see that her neutrophils, her white count was less than 1 all along, and platelets were really low as well. She developed acute aspiration, and she succumbed to death. And after her death, the culture taken the day prior grew Stenotrophomonas bacterium multifila, which actually was susceptible to trimsulfa. And we do see this in cancer patient or immune-compromised patient. We also see nocardia while the patient is on prophylaxis with trimethoprim sulfamethoxazole. So the lesson learned is predisposition to a wide range of infections, including with commensals. Infections with increased severity and rapid decline should be anticipated in these patients. Next case is a 48-year-old lady, again with promyelocytic leukemia. She developed profound neutropenia after chemo. She developed fevers, sinusitis. She also had right MCA infarct. She was put on vancomycin, cefepime, valacyclovir, and enbazome. She developed 6th cranial nerve palsy and the sphenoid biopsy grew Aspergillus flavus. She was switched to voriconazole. As you may know, the Aspergillus flavus is relatively. Do we see resistance here to amphotericin? There is known resistance for flavus, but anyway, for de-escalation, she was switched over to Vori. And 4 weeks later, she worsened clinically. Her MRI got worse. And this time, another biopsy was done. And unfortunately, she had mucor. So this is her CT. And so the lesson learned is basically these patients are at risk of multiple concurrent, superimposed, unusual infections. And sometimes missed diagnosis also needs to be considered. She might have had like hidden a non-septate hyphae within the septate hyphae that were seen, but unfortunately the culture also never grew. So if you look at the fungal classification on top, this is the Canada species. As you can see, it's very easy to miss any other morphology of fungal organisms behind this. Then this is the classic septate hyphae, the Aspergillus, Fusarium, Pseudospermum. And then these are the Mucorales, as you can see, these are non-septate hyphae. Again, within the classification, there are disclaimers that Mucorales genera can sometimes have this morphology in this category, and other organisms can be present. So it could be missed, and there has to be a very high vigilance that is required for these diagnoses. The next patient, unfortunately, these are all ladies, 52-year-old patient with nasopharyngeal carcinoma. Post chemo, she developed neutropenia. On exam, she had enlarged lymph node, cervical lymph node on one side. She had faint macular rash on the abdomen. The lymph node biopsy was negative for cancer. It showed inflammation with purulent debris. This is her CT of abdomen. Any takes on that? You see these hypodense lesions. I'm not sure how visible that is. Yeah, so this actually, these were also biopsied, negative for malignancy, blood culture, and liver lesion grew Candida glabrata. So, and her Bartonella and toxoserologies were negative. So the lesson learned from this case is unusual features and unusual dissemination of certain organisms. Like Candida typically has predilection for blood, heart valves, eye, but in cancer patients, you can see with neutropenia, we can see hepatosplenic candidiasis. So another case, just real quick, this is a gentleman with allogeneic AML, status post-allogeneic stem cell transplant, but he developed relapse. He was treated with chemo. He came with abdominal pain and fevers and diarrhea. He had very high CMV viremia. The colonoscopy and EGD showed duodenitis, ileitis, and colitis with crypt abscesses on the pathology. The biopsy CMV stain was negative, but the PCR was positive. He also had C. diff infection, and his skin biopsy showed graft versus host disease. This is his colonoscopy, and on the CT, as you can see, the inflamed bowel lining. And he was treated with ganciclovir for CMV viremia. But the viremia decreased, but it would not go, but persisted around like 4,000, 5,000 range. He also developed marrow suppression. He was already neutropenic. He was switched to letermovir, but whenever you do that, also consider adding HSV prophylaxis, because this does not cover HSV. For GVHD, he was treated with steroids and cyclosporin. And for C. diff, unfortunately, he was treated with PO, Vanc, IV metronidazole, rifaximin was added, but later switched to fidaxomicin. We do not typically do a test of cure for C. diff, but we did repeat his C. diff toxin, and it continued to stay positive. So it was a very challenging case. So it's not all about fungi and bacteria. We also have to remember other modalities like viral infections, graft versus host disease, and so on and so forth. So the common pathogens are our classic Staph aureus, coag-negative staph, streptococci, a gram-negative pathogen, which Dr. Sumaya very well covered, Pseudomonas over here. I was surprised, actually, the data, E. coli and Salmonella and Klebsiella. We also see fungal organisms, including Candida and Aspergillus, in the prolonged neutropenia. And whenever these patients, they continue to have fever, they're unresponsive to classic treatments, you should consider opportunistic infection with uncommon organisms. When to consider opportunistic infections is when the fever persists more than about a week, There is new organ involvement while the patient is on targeted antibiotic treatment. They develop new symptoms, new nodules, abscesses, and if they have history of prolonged neutropenia more than 10 days and have been on prophylactic antibiotics and antifungal, and yet they develop infections. So this is a list of organisms other than common organisms. I included nocardia, listeria, stenotrophomonas, mycobacteria, and should be salmonella, should be over here. The viral infections, the herpes viruses, and BK polioma and post-transplant HTLV1, fungal organisms, Aspergillus, Candida. Candidozemia is actually a new name for Candida auris. Candidozemia auris has been declassified from the Candida species. Mucor, then endemic fungi we have to consider like cocci, blasto in the States, I'm not sure about here, pneumocystis. Parasites, toxoplasma, strongyloides, typically post-transplant cases. And we also have to consider other modalities that may lead to cytokine storms like hemophagocytic lymphohistiocytosis and post-chimeric antigen receptor treatment, the CAR-T, the hemophagocytic lymphohistiocytosis, the cytokine release syndrome. It was a massive inflammatory response that happened after these immune modulator treatments. And drug reactions also need to be considered. I did see a patient who had actually high-grade fevers in the setting of neutropenia, severe rash, but it was because of beta-lactams, and she had known allergy to beta-lactams. Not many, we do see many cases such like that. So diagnostics, again, it depends upon the patient's clinical picture. You have to do basic labs. I will just highlight a couple of things amongst diagnostics. PCR modalities are taking really lead, and they really help us in diagnosing a problem earlier. And, we have to be cautious when we interpret these PCR panels also. We have to be cautious of the colonizers, but really they do help us expedite the diagnosis and treatment. In fungal serologies, fungal assays, antibodies, imaging, biopsy if applies, but we have to be careful about weighing the risks and potential intervention risks. And then herpes viruses and other uncommon organisms that we talked about. In order to prevent neutropenic fevers, GCSF considered in high-risk regimens, antimicrobial prophylaxis typically with Pseudomonas-specific antibiotic, fluoroquinolone, antifungal prophylaxis in high-risk patients, HSV prophylaxis in seropositive patients, and vaccination to prevent any preventable diseases. We have to be sure that they are protected, and hospital-acquired infection precautions. When we talk about management, typically, the antibiotic has to be started empirically within the first hour, and the patient has to be monitored for the forthcoming, 4 or 5 hours. If they have clinical improvement, oral fluoroquinolone plus amoxicillin clavonate can be considered as an outpatient, and if they don't defervise, consider admission and close monitoring. For inpatients, it's considered medical emergency. Again, this is beyond the scope of the discussion. The targeted, with the things that you should remember, there should be empiric broad spectrum antibiotic choice, including Pseudomonas coverage, MDROs if the patient is colonized, and if they have had recent prior infection with drug-resistant organisms like MRSA, VRE. We have a high risk, unfortunately, of VRE at our organization. The carbapenem, the ESBL producing organisms, we consider carbapenem, and we're not talking about the advanced classes like the NDMs, the KPCs, the OXA48s. If we generally do not recommend empiric coverage for those organisms with ceftazidime-AVI or cefiderocol, but if the patient, let's say, if he has had an infection with an NDM, Enterobacterales, like 2 weeks before, and they're neutropenic and they're really sick, then empiric coverage might be justified. And antifungal coverage if the fevers persist. For those, the 2 main organisms that we have to cover are Aspergillus and Mucor based on clinical suspicion. And, isovuconazole is a really good one. It covers both. With posaconazole is also good, but really sparsely available. I'm not sure about here. And Vori does not cover Mucor. So ampho is toxic, but we can use it cautiously. Always consider allergies and contraindications, de-escalation based on the cultures, consider stopping empiric antibiotics if the culture is negative by 72 hours, and prognosis really depends upon, mortality depends upon severity and the delay in treatment, and early recognition does improve survival. I wanted to bring a number for you guys for the mortality prediction, but really there's just really off the chart. Some places it's 5%, some places it's 30%, some places it's even more than that. And with the drug-resistant organisms that are evolving, it's really getting a huge, huge challenge we have to be very concerned about. That's all I have to say. Thank you.
Thank you, Dr. Satash. I think we'll take the questions at the end of the session. Um, So now we will move to our last talk of the session, and this will be given by Dr. Amjad Mehboob, who is a professor of medicine at Gaju Khan Medical College, Sawabi, and a visiting consultant and head of division of infectious diseases at Bacha Khan Medical Complex, Sawabi. And he's an old friend, and he is the he was the first ID physician in KPK, and until recently, he was the only ID physician in KPK, and it was not in Peshawar, he was in Sawabi. So over to you, Dr. Amjad.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Owen, for the introduction, and thank you, Shaukat Khanum, for inviting me for this talk. When I was given this title, Management of Line Infection, I was not sure if it is just superficial, deep, central, which line. But this was a huge, lengthy topic and the topic of interest to everyone managing cancer patients. So the cancer patients are much more vulnerable to infections, and the risk of dying from an infection is nearly 3 times higher than for people without cancer. And this is all because it is related to the disease burden and similarly treatment-related immunosuppression in these patients. The line infections are actually a driver for the MDR, but luckily we are not progressing rapidly, as Dr. Somaya mentioned in her presentation, but it is a slowly and gradually visible problem in all our patients. So in just a background, more than 5 million central lines are inserted in US annually, and the frequency of clepsy in cancer patients is from 0.5 to 10% per 1,000 CVC days. The rate of catheter-related infections in cancer patients reported in literature varies from 9 to 80% depending on different scenarios and different sets of cancer patients. The associated mortality ranges from 12 to 40% depending on several factors, including patient comorbidities, CVC type, and the microorganism causing the infection. Importantly, up to 70% of all CRIs may be preventable with current evidence-based strategies. So this is actually the area where we need to invest the maximum. So sources of infection in general, they could be extraluminal, patient's own skin and the microflora, microorganisms transferred by the hands of the healthcare workers, contaminated entry ports, catheter tip prior or during insertion, contaminated disinfection solutions invading wounds, site selection. The other one is intraluminal spread, contaminated infusate and fluid and medication. Huge challenge, especially where the medication are not prepared as per the required protocols. And these biofilm, these lines could be seeded with from the hematogenous spread and infection from a distant focus. So based on clinical symptoms and laboratory findings, localized infections of CVC like exit site infections, tunnel infections, and port pocket infections are distinguished from the central line associated infections are cryptopsy. What are the risk factors to get these infection is high level of colonization at the insertion site and catheter hub, as well as the administration of blood products and total parenteral nutrition. Patients requiring more than one CVC are at higher risk of CRI. And among cancer patients with hematological malignancies are at higher risk of CRI compared with patients with solid tumors. Neutropenia is a major independent risk factor for a central line related infection. Though the cases mentioned in the morning were female, but here we notice that it is male gender, disease burden, disease stage, age, and reduced performance status. Rates of CRI also depend on the devices used, and the risk of CRI differs between cuffed, tunneled CVC, subcutaneous, implanted ports, peripheral inserted CVCs, or percutaneous non-cuffed or tunneled CVCs. So this is one of the recent publication which is showing the risk factor for catheter-related BSIs in a high-risk cancer patient population. So neutropenia and prior catheter, site of catheter, and those who receive blood products through the catheter, they are at a higher risk of. Similarly, catheter site of a cephalic or basilic, they are even at higher risk. So in general, what's a CLEPSY? It's an infection that originates from or is related to a central venous catheter. There is a surveillance case definition for the IPC team, then there is a clinical case definition. There is an NHSN criteria which is becoming tougher for the resource limited settings. That's why WHO introduced its case definition for the surveillance purposes, and there is a ECDC definition as well. So in the WHO case definition, why I'm just posting it over here, this is something which gradually the country is pushing for the HAI surveillance, that this is comparatively easy and doable in resource limited settings in the whole country. So in advanced centers, yes, the NHSN is fine enough, but for the rest, this is validated, and this is now the plan for the HAI surveillance is to follow this definition in the country. Clinical definition of epilepsy, it's occurs when these three criteria exist: clinical signs of infection, fever, rigors, altered status, mental status, and hypotension. No alternate source of bloodstream infection, and positive blood culture from a peripheral vein with any one of the following: catheter tip or segment culture that matches organism grown from the blood, at least threefold higher number of organisms grown from the catheter versus the peripheral blood culture on simultaneously drawn cultures, and growth from the catheter drawn blood culture occur at least 2 hours before growth of the same organism, which is the differential time to positivity. Alternatively, if a peripheral blood culture cannot be obtained, then diagnosis can be made when 2 or more lumens of a CVC are positive for the same organism. So this is the diagnostic criteria. It's a definite CREPSI. So growth of same pathogen from the blood culture of the peripheral vein and from culture of CVC tip, plus our growth of the same pathogen from blood culture of CVC and from blood culture of peripheral vein, plus in vitro susceptibility testing result in the same resistant pattern, and a differential time to positivity of more than or equal to 2 hours, or for quantitative blood culture more than threefold greater colony count. So DTP, this differential time to positivity, is not accurate for these two organisms, which is Staph aureus and Candida. A probable CREPSI is growth of the same pathogen from blood culture of CVC and from blood culture of the peripheral vein, and no criteria of definite CREPSI. And detection of quag-negative Staph aureus or Candida species. So the exit site infection, tunnel infection, and pocket infection, they are important because clinical signs of infection are less than 2 centimeters are equal from the CVC exit and BSI without criteria of definitive CREPSI. And clinical signs of infection more than 2 10 centimeter from CVC exit site in the tunnel infection along with subcutaneous part of CVC and BSI without criteria for definitive CREPC. Pocket infection, implanted port system, its clinical signs of infection of subcutaneous pocket and a BSI without criteria for definitive CREPC. Similarly, the rest that is for this time it is quite. So standard procedures in the diagnosis of a CVC related infection before a CVC removal, rule out other possible sources of infection by clinical examination and imaging procedure if necessary. Inspect the CVC insertion site or pocket or tunnel for signs of local inspection. Palpate the pocket or tunnel. Do not take skin swabs or they have limited validity to confirm or rule out local CRI in clinical routine. Take one pair of blood cultures, aerobic and anaerobic, from a peripheral vein and one from the CVC for microbiological evaluation. In case of multi-lumen CVC, draw separate blood cultures from each lumen. Determine the differential time to positivity between CVC and peripheral blood culture sample for pathogens other than Staph aureus and Candida. Do not use DTP in patients with Candidemia or Staph aureus for diagnosis or exclusion of Klebsiella as a decision tool for CVC preservation. Do not use endoluminal brushing for routine diagnosis. After CVC removal, we will be discussing this tip culture in another slide. The biggest question is this a contamination or not? So the possibility of culture contamination should be considered when determining a treatment course. A single blood culture from any site growing a common skin contaminant likely represent a contaminated blood culture. If an initial single positive blood culture grows cons or other common skin contaminants in a patient with clinical suspicion for infection, then additional culture from the CVC and peripheral site should be obtained to help rule out contamination. But in immunocompromised patient, a single positive blood culture with an organism considered to be skin flora can represent a true infection, and determination of contaminated blood culture should be made carefully as discussed. So central venous catheter related bloodstream infection in cancer patients. So 89, this is a study from the Armed Forces Institute of Pathology. 89 patients were included and the frequency of CREPC was 17%. Out of the 19 organism isolated, 10 were gram-positive cocci, 8 were negative rods, and 1 was a fungus. Cons 27% were the predominant pathogen. And among the Staph 46 were MRSA. So catheter tip culture, this is something we always say, no, don't do it. Catheter tip culture should be obtained in any CVC removed due to suspicion of, but not prior confirmation of a CREPC. If there is still a suspicion and you have removed the line, then you can go for it. If CREPC has been diagnosed by a positive blood culture, culture of the catheter tip may not change the clinical management. Growth of more than 15 colony-forming unit per plate from a 5 centimeter tip using the roll plate technique is suggestive of an infection. So in patient without sign or symptoms of infection, routine catheter tip culture upon removal of a catheter is not recommended, as positive cultures may most likely indicate colonization rather than a true infection. So early CVC removal is particularly encouraged in patients with a deteriorating clinical state, sepsis, septic shock, or in case of severe complication such as endocarditis, septic thrombosis, abscess formation, or osteomyelitis. Prompt removal is warranted in any case of continued positive blood culture 72 hours after initiation of therapy in spite of appropriate antimicrobial therapy. Preservation of CVC may be initially attempted in clinically stable patient in the presence of cons. Antimicrobial lock technique may be an option for highly needed infected implantable catheters in conjunction with systemic antibiotic therapy. Modify systemic antibiotic treatment according to microbiological results of susceptibility testing. The antimicrobials. So many Klebsiella are caused by gram-positive organism. Therefore, empiric coverage for gram-positive organism should be started after the cultures are obtained. An empiric coverage for gram-negative organism should also be aided pending culture results if the patient shows evidence of aseptic shock, has a hemodialysis catheter, is neutropenic, has a femoral CVC, has a history of short gut syndrome, has a history of solid organ transplant, known focus for gram-negative infection, and recent history of broad-spectrum antibiotics within the last 90 days. In patient with severe sepsis or history of MDR gram-negative organism, a second gram-negative agent should be added to provide expanded coverage in the setting of potentially resistant organisms. This broadened coverage can be achieved by adding either aminoglycoside to the peptazobactam or cefepime or changing antibiotic regimen with a broader coverage such as a carbapenem or colistin nowadays. Antifungals. The RCTs have not demonstrated any mortality benefit to the use of empiric antifungals in immunocompetent critically ill patients. But some population where empiric therapy may be considered include those patients who have esophageal perforations pending culture results, recent abdominal surgery with recurrent GI perforation and anastomotic leaks, immunocompromised patient at high risk of invasive candidiasis who are not receiving systemic antifungal prophylaxis. So initial antimicrobial regimen may be continued in case of clinical response to empiric treatment without microbiological evidence of insufficient antibiotic coverage. For uncomplicated CRI, continue antibiotic treatment for about 7 days depending on the causative pathogen, counting the days of the first sterile blood culture as day 1 of the treatment. And at least 2 weeks of systemic antimicrobial treatment is recommended in immunocompromised patients. This is just a rough summary for the organ-specific therapies and the usual duration. So for the gram-positive, it is usually 2 weeks. For the cons, it is 5 to 7 days. For the enterococcus, it is again 5 to 7 days after defervescence. And Stenotrophomonas and these resistant organisms all require roughly 2 weeks of therapy. Antibiotic lock therapy. In scenarios where the catheter is retained and it is often difficult to clear the infection with systemic antimicrobial treatment alone due to the likely development of an intraluminal biofilm resulting in high recurrence rates. So it is by instilling a high concentration of antibiotic into the intraluminal space and allowing the antibiotic to dwell for an extended period. The rate of successful infection clearance is increased. Antibiotic lock treatment may be considered for treatment of where there is no signs of exit site or tunnel infection for which catheter salvage is a goal. So you can have an exit site infection without a clepsy. You can have a tunnel site infection without a clepsy. But if they have a clepsy in combination, then removal is the option. But if you do not have a exit site or tunnel site infection with a clepsy, then you can use ALT for salvage in certain organisms. The antibiotic selected for lock therapy should be comparable to the systemic antibiotic chosen. So you can use many antibiotics for the ALT. It could be vancomycin, aminoglycoside, or some other. Than similarly, you can use non-antimicrobials like ethanol and taurolidine derived. So for patient with multiple positive catheter-drawn blood culture that grow cons and concurrent negative peripheral blood cultures, ALT can be given without systemic therapy for 10 to 14 days. For all other situations, antibiotic lock therapy should not be used alone and should be used in conjunction with systemic antimicrobial therapy. So the procedure of ALT is actually not standardized and considerable variability between different protocols concerning the antibiotic solution used, concentrations and dwelling time and the duration of ALT and the simultaneous use of the infected catheter has been reported. It will be less effective in Klebsiella caused by Staph aureus, Candida, and other microorganisms embedded in biofilms. The preferred management of a confirmed CREPC include removal of the CVC in most cases. However, there are some circumstances in which the removal of the catheter may not be possible. In cases where removal is not possible, the clinician must carefully evaluate the risk and benefits of alternative treatment on individual basis and with the benefit of additional expert guidance. So these are the organisms for which removal is the option. I still don't know if Acinetobacter is there or not, but I have yet to find any study which is showing that Acinetobacter, because that is our problem. Guide wire exchange is not ideal, but may be considered if catheter removal is not feasible, but with the following prerequisites. There is no tunnel or exit site infection. There is no other site for new catheter placement. Bacteremia has resolved, and there is no metastatic site of infection. So data supporting the practice of changing CVC or a wire are weak and is discouraged. Exchanging a CVC or a guide wire should always be accompanied by full antibiotic therapy. When to place a new CVC when you remove a line? Unless there is an urgent need for CVC access, central venous access, new CVC placement should be delayed until at least 48 hours after the first negative blood culture when treating a bloodstream infection, including a CREPC. A small study showed that PICs placed within 2 days of documented bacteremia had an increased risk of relapse of bacteremia when compared to PICs placed at least 3 days after documentation of a negative blood culture. So the longer the better. Complication, specifically in adults, valvular involvement and cardiac devices patients. So for that, you need to do this monitoring in all those patients who had epilepsy or CREPC. And a search for other metastatic foci should be undertaken in any patient with persistent bacteremia. Joint vertebral osteomyelitis, splenic abscesses, secondary infection of prosthetic material should be considered. And this is specifically true for patients with Staph aureus bacteremia, as it's the most common bacteremia associated with vertebral osteomyelitis. Prophylaxis of antibiotic for reducing CLEPC, they are not going to change the outcome. So there is no significant difference and of no use. When to consult ID? When they are available. Or agar available now, then you manage it on your own. So these are some of the scenarios where you can consult them. When you have these organisms, patient with catheter, where catheter removal is not an option, patient with cardiovascular implantable electronic device, or endovascular implants or orthopedic hardware, patient with complications such as endocarditis and other metastatic infection, patient with bacteremia lasting more than 72 hours after appropriate treatment. So antibiotic and catheter replacement stewardship do not routinely perform replacement of CVCs. Apply systemic prophylactic antibiotic treatment before insertion. Apply topical antibiotic ointments. So targeted prophylaxis antibiotic lock therapy should be limited to persisting high baseline rates of CRI in high-risk patients with long-term catheters. And antimicrobial CVC may be useful for patients with long-term CVCs in case of persisting high CRI rate despite comprehensive preventive bundles. Diagnostic stewardship, implement rapid diagnostic testing, especially in outpatient setting where empiric prescribing is vulnerable to failure. Similarly, when you have very diverse group of organisms as a cause, and tailored guidelines according to your own antibiograms. So with this, I conclude. This is a picture from my training year, then this is a picture from my current hospital. Thank you.
Thank you very much. So if you have any questions, we are open to questions now.
On it? Okay. So I'm Halima Saeed, pediatric oncologist at Shaukat Khanum Hospital. And obviously, we do lose a lot of patients to multi-drug resistant gram-negative organisms. So that's a big concern. My question is for empiric coverage in febrile neutropenia. You clearly showed that there is less than 50% sensitivity to piptaz, and we are persisting to use piptaz as our empiric cover. And I know we don't want MDR E. coli either. You advocate something that most of our E. coli is that is would it double empiric cover be something to consider, but is the highly what our empiric cover is?
So unfortunately, yes, TESO numbers, the resistant rate is going down. We might have to review our empirical antibiotic guidelines. That must be something that we would have to review. Regarding aminoglycosides, the numbers are not that great if your bug is already carbapenem resistant. I can go back and actually show a side-by-side comparison. But existing guidelines actually do recommend that you could add an aminoglycoside to your carbapenem to actually improve coverage. But if your bug is already carbapenem resistant, it's not going to be very helpful. We do not recommend adding colistin at this point either about with your as an empirical therapy. But the best thing to do would be to send your cultures early to get your antibiotic results early so that you can modify your therapy early. That would be the best way to go about. But yes, we might have to sit down collectively and then review our empiric antibiotic therapy policy. Ramjit?
So one of the basic point to know about empiricism in any infection is how much is the resistance in your antibiogram. You can use anything where the resistance is less than 20 and at the most 30%. If it is more than 30%, then it is no more empiric. But as we know that the organisms that we are having, all of them are hovering somewhere between 60, 50, even 65%. So the best is you start empirically, yes, by adding an aminoglycoside for the first 48 hours and follow the culture. So without a culture, persistently using something is again a challenge, but you have a good antibiogram and you know that. But if I look into the antibiogram of Shaukat Khanum, I can clearly say that you actually do not have options to choose from what you have. So the best is a close monitoring, follow your culture as early. If you ever develop a point of care rapid test for these resistance, that will be another addition to the better cover.
If I may add a few points, I think this antibiogram includes, or these bacteria includes all the positive cultures, not only the bloodstream infections. So the patients with UTI, they mostly we see carbapenem resistant E. coli in those patients. So the major chunk, I think, or it's all
I
bacteria.
think she said only
It's
bloodstream.
just bloodstream infection.
not
Okay, all right. Okay. Anyway, I mean, we do not have much choice here. So we need to conserve antibiotic, because if we start using carbapenem empirically, then where will it end? So I understand that the important thing is that we need to review, and we do review. ID team at Shaukat Khanum, they do review these guidelines and antibiogram quarterly and annually as well. And based on that, we can consider changing the antibiogram, our choice of antibiotic. But the important point which I would like to emphasize is that de-escalation of antibiotic, which is not being practiced, and we are struggling with that. That if the patient is on piptaz, and if the now is non-neutropenic, and if the bug is ciprofloxacin sensitive or ceftriaxone sensitive, usually there is some the physicians are not comfortable in de-escalating piperacillin tazobactam to other antibiotics. So that is one of the major challenge, because this is not a controlled drug or not a restricted drug. So we cannot monitor that. But this is one of the major challenges which we are facing here. So I mean, yeah, we'll review that.
The question, if no one else has one, is for the double cultures for central line, like the getting the pediatric challenge. Thanks. How important is that? Like, what, how much of a difference does that make? You just present culture and not get a practical.
So if you are interested in saving the line and you are interested in reporting a HAI, you do not have options, but you have to follow. If otherwise, if you have double lumen, a line with multiple lumen, you can actually collect it from all the lumen. You actually have to collect sample from each lumen. वहाँ पे भी the problem is like we are worried, oh, this will be a huge, if this is a triple lumen catheter, I will be collecting a sample from each. But it is something not impossible that you will say that we cannot collect. We can, but if the body mass of that baby is like that, is just 3-5 kgs, then you may not be able to label it at the end of the day. Was it a HAI or not, or I'm just treating this patient and I'm not concerned about that. But it is a requirement standard if you are considering that this line can be a source, because at the end of the day, if you get an organism from that line and you cannot fix it, if it is from the line or somewhere else, and you are deciding about the line salvage or line removal, how will you decide if you do not have a peripheral? Will be a difficult situation.
To that. That understandably is a very common situation, especially when we're not able to get a peripheral culture. Again, I would suggest seek ID opinion because certain organisms are considered commensals. For example, of a coag negative that it took 48 hours to grow only from one port, maybe just a contaminant, along with a low procalcitonin, and if the patient defervises very quickly. So yeah, depends on the organism also.
Um, uh, any more questions from the audience? Yeah, Dr. Usman.
Apology to my consultant. I got a follow-on question from both sides and comment from there as well. That quite often we have got a patient who's really immunocompromised and we have grown a bug. And then we have got an antibiotic, like for example, patient is on piptaz or meropenem, and there is ongoing fever, and the patient is not improving and actually rather getting unwell. So I think that we would like an advice on that, how to move forward from there onwards, and will that de-escalation work there as well?
Yeah, I'll let Dr. Zartash to answer that, because I will answer that later on if required.
You have to be brave. So yes, de-escalation. If the patient is persistently febrile, unfortunately, we do see these in febrile neutropenic patients that they can be febrile without a cause. Also, the important thing is to look for other things. Do they have a DVT? Do they have a good physical exam? And then again, according to the guidelines, after a week, if they're persistently febrile, we look for unusual organisms and add fungal coverage. And then still, with thorough investigation, if we do not find anything, it's best to de-escalate and stop and look for other causes.
Yeah, and I was pointing out the scenarios in which we have a bug and the patient is relatively stable. So in those scenarios, and a particular patient is non-neutropenic, so in that scenario, we should de-escalate. And even if the patient is neutropenic and he's on carbapenem and the bug is now sensitive to piptaz, then we should de-escalate. Or if it's sensitive to cefepime, then we should de-escalate to that antibiotic rather than to a anti-pseudomonal antibiotic. So that was actually a whole point.
Very important, because we're losing drugs because of these empiric coverages. We're going to last resorts, and unfortunately, we don't have an option to lose these. We have to save them.
Yeah. Right. So we, since this is a hybrid session, so we have, I think, around 70 participants online, and we have a number of questions online as well. So the question is, does current typhoid vaccine confers immunity to Salmonella paratyphi? And also, how can we make sure that, like XDR typhoid, we can prevent XDR paratyphi strain from emerging?
So the current conjugate vaccine does not actually cover paratyphi. It does not. And at the end of the day, it's all about antibiotic stewardship. It's about using the right antibiotic to treat your patient. But first of all, typhoid का जो basic जो मकसद है उसको control करने का, it's all wash, clean food, clean water, wash your hands, and don't eat outside. So unless and until we ensure those practices, this is not going to help. So there's something that Dr. Altaf always says, that prevention is actually cheaper than cure. So let's not go on the more expensive options of treating typhoid. Let's just focus on preventing typhoid. So let's focus on that. And as long as those, actions are reinforced, that's the only way typhoid can be controlled.
Okay, so we have another question from Ms. Maimuna. Do we have any consolidated national antibiogram? If yes, do we have any guidelines for empiric antibiotics for common infections?
So there should be no national antibiogram. It should be regional institution specific. Anything like a national antibiogram is not something that we know about. So it is always regional and then specific to specialized. If it's a burn unit, then you follow a burn unit antibiogram. If it's an oncology unit, you follow that specific oncology unit antibiogram. If you are in a general hospital or in a specific remote area or a central area, then you have to follow their own antibiogram. So you cannot fix it for all at once. You have to follow it.
Yeah, very right. Because we have prepared our own guidelines for common infections based on our own antibiogram and keeping in view the national and international data, as well as our own antibiogram. And we modified these guidelines for common infections at SKM. Right. Okay. So another question, I think, this is for Dr. Amjad. I'm Dr. Atikur Rahman from North Waziristan. My question is directed to Dr. Amjad Mehboob. In which clinical scenario is antibiotic lock therapy preferred instead of removing an infected catheter? Are there specific patient conditions or infection types where this approach is more beneficial?
So there are certain organisms for which you cannot use them. They are the patients who are comparatively stable and you just want to save this line. And they are not the one with complication. They are not the lines with complication. They are not the line with the port site infection. They are not the line with the exit site infection. So there are very limited scenarios where actually you can use an ALCR. There is a catheter which you do not have any option, but you want to keep it for according to the patient condition or current scenario where you cannot replace it immediately or urgently.
Right. Can I ask Dr. Sumaya a question? You presented gram negatives data. So is there any change in our shift in gram positives as well, particularly Staph aureus during these two time periods?
So we didn't actually, put the data on top of this to actually compare the numbers directly. But if I were to, because we have a look at all the cultures that come into our lab routinely, so we are actually seeing the numbers go up for Staph aureus bacteremia, especially MRSA. We're not seeing a lot of VREs, which is actually better. We're not seeing a lot of enterococcal infections, but yes, we are seeing an upsurge in Staph aureus bacteremia. So if I have to put the numbers together, it might not be as high as E. coli like we presented, but the numbers are on the rise. We'll have to just put the numbers together and match them.
Right. Thank you.
One explanation that we need to be clear about is about these ratios that we always think of, gram negative बढ़ रहा है या gram positive बढ़ रहा है. So in cancer patient, mucosal injury is a very common form of bacteremia, which is not in the other immunocompetent patients. So if you go to the ratios between different sets of patients, yes, gram negative could be more in cancer patients who are severely immunocompromised because of mucosal barrier issues. But in general, it is still gram positive in most of the other scenarios.
Right. Okay. One last question from Dr. Zartash. In the patient R, I guess, you used voriconazole and ATT together. The first patient, I think, if I remember correctly. So, I mean, because our ID pharmacists, they'd always have reservations using voriconazole with rifampicin.
Yeah.
So, and we do have voriconazole levels. So do you use it with the monitoring of LFTs and voriconazole, or you just avoid rifampicin with voriconazole?
Yes, honestly speaking, that patient was treated for ATT before I took over the case. But yes, I do see cases where concurrently medications are used, and we vigilantly monitor the levels and LFTs. I believe that patient continued, and as far as post-intensive period, she was on INH alone.
Right.
Yeah.
Okay. So not
Yeah.
rifampicin.
Yeah.
Right. Okay. All right. Thank you very much. Thank you, everybody, for participating in the session, and thank you all the speakers and to present your presentation in this session. Thank you very much.